Hello students, today we shall learn about the next topic in the cardiovascular system. It is myocardial infarction. You were seeing in this picture here when I showed you, which actually says cardiac ischemia. So what is happening here? There is the disease in the artery for which there is actually a decrease in the blood supply. This decrease in the blood supply is actually not letting the heart to function effectively, and because of this decrease in the blood supply, it is causing tissue damage, and that is what you would see as the shaded portion behind the arteries. So this is myocardial infarction. Now, the most common signs and symptoms that you would see in patients experiencing this condition is obviously chest pain. Okay. So chest pain, chest discomfort, and the pain can be of varying levels. Okay, it can be just like a slight discomfort, or it can be like a burning sensation. It can be a radiating pain. It can also be like a throbbing pain, that is very, very severe pain. It can also be like, the patient may also complain of somebody like crushing on their chest. So the pain can also be that intense. Okay. The pain that is occurring in the chest can also be radiating, which means it is moving, or rather it is spreading to the shoulder, to the arm, to the to the back, maybe also to the neck, to the jaw area as well. So this is how you would assess the patient when they come in, asking about the pain, when it started, was it radiating. So with that, you will be in a position to diagnose the exact. That is also called as something silent MI, or silent myocardial infarction. So what is the meaning of it? It occurs without any symptoms. So that is pretty dangerous because the patient will not know what is happening. So he would just be performing his normal routine activities. There may not be any pain, but suddenly you never know, he had a heart attack, and maybe the heart or didn't even experience any kind of throbbing pain, or the patient also didn't experience any kind of throbbing pain. So most commonly this is seen among women and people with diabetes. So the comorbidities, that is why we say people with comorbidities, it is a bit of a troubled condition or a situation, because due to all these other existing illnesses, some of the major illnesses can also go in a different path. And this is why we say a silent MI can occurs very silently, means what? There are no symptoms experienced by the patient. So you wouldn't actually know what is going on. Maybe he's had a heart attack, and maybe finally suddenly he just collapses. You never know why this has happened. So when there is a chest pain, you know that yes, there is something really going on with the heart. So usually what happens, once you do the thorough physical examination of the patient, you perform an ECG, and maybe during all the situations, once you read through the ECG, maybe the patient has come for his physical examination on a routine basis, but performing an investigation, tests and checks along with the routine ECG may help you find out, oh yes, this person has had a previous myocardial infarction, and that was a silent one because the person did not experience any kind of symptoms like a simple chest pain as well. Okay, and that I will tell you how, because all this can be interpreted with your electro. Now, this picture actually here shows you how the person is experiencing the chest pain. So he can be just holding onto the chest. As I told you, the pain can be of varying levels. And this is how that particular demand for that, circulation and oxygen supply actually causes an effect or impact on the heart. So you can see that this portion of when you see the picture of the heart here, you will see one portion is slightly bluish, means definitely there is no circulation happening there. And when you take a cross section of it, you can see the amount of tissue that is being damaged. So that is called as the area of infarct, and this is a particular situation that is going on in a person having myocardial. So myocardial infarction occurs due to various reasons. Okay, so the reasons are actually the baseline reasons, as we have learned even during our atherosclerosis topic, that still continues. Okay, so the bases are all like it can be both modifying factors as well as non-modifying factors. The etiology, again, it starts off with the plaque formation, or rather atherosclerosis. What is it? Formation of clot and narrowing of the lumen, and there is no supply of adequate amount of blood to the heart muscle. So eventually what is going to happen, that portion of the heart is not going to get adequate blood supply, and that is called as the area of infarct. Okay, And this particular condition, so you can you can very well appreciate in this picture here, when you look at the heart muscle, and that is actually shown you as an enlargement here, what is going on within the coronary artery. So this is a coronary artery, and this is the LAD, that is left anterior descending artery, the artery that passes in front of the heart, which is very important. And you will see what is going on within the arteries. Yes, there is definitely plaque formation, or rather atherosclerosis. Again, the lumen is quite narrowed, means the heart is not receiving adequate supply of blood. Also, what happens slowly, there is also a thrombus formation, or rather a clot formation, that is again going to hinder or hamper the circulation flow. And eventually, the heart muscle is in trouble. That's going to be ending up with an infarct. Again, a picture just showing you about the heart muscle, what is going on, and it can occur anywhere in the artery. So this is actually a branched picture. Okay, so that is why I'm telling you it can occur anywhere, and any portion of the heart muscle can be. Now, the myocardial infarction can be classified into 6 types. Okay, so the type 1 myocardial infarction is basically related to the ischemia due to the primary coronary event. So primary coronary event is nothing but what happens in the beginning. Okay, so the beginning is what we mentioned as the formation of the fatty deposits, or rather the plaque formation, which actually hampers the circulation through the coronary arteries. So in such situation, if the patient ends up in the hospital with a severe chest pain, and even before the tissue damage has actually occurred, then we call that type of a MI as a type 1 myocardial infarction, because basically it is because of the narrowing of the lumen. The heart muscle was not able to receive adequate amount of blood. Now, type 2 myocardial infarction, what happens here is it is secondary to ischemia. That is what happens, there is increased demand for the oxygen and blood supply. So what happens, why it happens, again the lesions are very tight. That means the plaque formation has been there for a long time. It is really hard and narrowed. The lumen is quite narrow, and the heart is not able to receive adequate amount of blood. The demand is more by the heart muscle. So when that condition occurs, means what, it is quite severe. You will see all this changes on an ECG, and with that you will be able to appreciate how severe the myocardial infarction is. So the type 2 is mainly because of the increased increased oxygen demand, and decreased supply of the, or decreased circulation to the heart muscle. Now, type 3 myocardial infarction, what happens, it can be also resulting in unexpected cardiac death, okay, and with symptoms suggestive of myocardial ischemia. So when the disease is severe, the vessels are quite diseased and narrowed and not able to supply adequately. It can result in sudden cardiac death as well. Type 4, what happens is, after the patient has had this chest pain, he comes to the hospital. Here the immediate management will be performed, and maybe he's had an angiogram followed by a percutaneous coronary intervention, which is nothing but the stent is actually put in. Okay, so what happens sometimes, there can be thrombosis or clot formation within. Okay, so within the stent itself, again, there may be clot formation for some reason. Maybe the body is designed that way. The body is not. He's already had a lot of cholesterol issues, or maybe a lot of his triglycerides are high. His the bad cholesterol is high, and all this so may contribute to these factors. And for some reason, maybe the blood also is not thin enough to flow. That is why we say, once the patient has had a stent, and I mentioned this to you in the previous session, it's very, very important he should not miss on his blood thinners medications. Okay, so this also can be the cause. And when again the patient ends up in the hospital with the same chest pain, and when it is re-examined and diagnosis is being performed, and angiography is again being performed, if you feel, if you see the stent is again being blocked, then we classify that type of a myocardial infarction as a type 4 myocardial infarction. And type 5 myocardial infarction means it is associated with a cardiac surgery. So when we say cardiac surgery, means what? Yes, the person has had a bypass, and I also showed you that in the previous sessions how the bypass is being done by grafting, which is nothing but you're taking the leg arteries or the veins from the leg, and then you're trying to create a bypass. Okay, there's nothing but you're providing a different route of circulation to the heart muscle. So wherever the heart muscle arteries are damaged or diseased, you are rerouting it with a proper pathway where the circulation is happening. And if any of these grafts are damaged, means what, the patient may again come back to the hospital complaining of severe chest pain or any other sort of discomfort, and for some reason he has collapsed or something like that. And then when you do the diagnosis and when you assess the patient, maybe if you see that the grafts have been damaged or it's blocked again, then that type of myocardial infarction is classified as type 5 myocardial infarction. Now, what causes the final when we say injury to the heart muscle? So when does that happen? It is multifactorial. Okay, a lot of factors contribute to this, and also based on change in the cardiac troponin concentrations. So again, as we mentioned in the previous sessions as well, when you know that there is injury to the heart muscle, you know that the body releases these enzymes and proteins, which is not supposed to be there when it is at the normal phase. So increasing rise of this, and immediately during injury, it is the troponin level that rises. So that is why we do the complete blood profile along with the cardiac enzymes and proteins. So troponin and myoglobin is nothing but the cardiac proteins, and also we do the cardiac enzymes, which is CKMB. Okay, so these are the important investigations you would do to assess, and this will actually indicate the level of myocardial injury. So when we know that there is increasing level of troponin rise, means yes, this usually happens just when the injury has started. So troponin levels rise, and the myoglobin levels are again once when there is a complete infarction that has occurred, and then you will when there is complete death of the myocardial tissue, and the levels are increasing. And once the management is being provided, and then again when you assess the levels of the myoglobin, maybe you will begin to see that these levels are decreasing. Means what? There is not much of the tissue damage that has occurred. Also, you will see that the CKMB levels, and all these are the cardiac biomarkers, that is what it's called, because these and on a normal phase or normal pace, these are not being released or produced by the body. So this is a classification of myocarditis indicating necrosis. Okay, so that means that damage is quite severe. Zone of injury, again, this is just giving you an explanation. So once you relate to the picture and you read this, you will know what is actually happening. So damage to the heart muscle is classified as 3, that is zone of necrosis, zone of injury, and zone of heart is going to end up in necrosis. And when you say the area of infarction, means yes, this is not a good looking ECG wave because you have the deep Q wave. When you see the pathological Q waves occurring, that means yes, there is severe damage or injury to the heart muscle, and that is called as a Q wave, because normally in a ECG the Q wave is not this deep. Okay, so when it is quite deep, it is like 2 mm in depth, 2 mm and more, then it's suggestive of injury. Okay, and also you see the infarction means yes, the person is, yes, it is truly a myocardial infarction, and yes, it is quite severe. So this is how we say that is why we also insist to do a complete 12 lead ECG, and this is very, very crucial and important when the patient presents himself to the emergency department with a chest pain. And again, this is just explaining to you the ECG. So once you go through this, you know, I've already explained to you what the deflections mean in my previous session, and this is actually telling you about the different waves, that is PQ, RS, and all the intervals, the segments, everything is explained here. So just kind of again, during this myocardial infarction, now this ECG that you see here is nothing but the Q wave is present, which is a normal rhythm again, and the non-Q wave is also present again. That means when you say the Q wave is there, means what? Yes, there is the initial phase of the ventricular depolarization. So sometimes what happens is the Q wave is also absent. Okay. So that is also a non-Q wave ECG. Again, as I told you, you need to know the patient's history, maybe whether the patient has had any kind of myocardial infarction in the past, or injury, or ischemia, or has he not presented himself to the hospital with any such condition. So this is maybe the presentation of the patient, it's called as a Q wave is present and a myocardial infarction. In this picture here, you see the Q waves. So this is very normal. Okay, so the Q wave should be less than 2 mm. So it is like, you know, less than 2 boxes. So 1 mm is one tiny box. So this is a very normal presentation of a Q wave, and normally it is non-pathological, means not much of injury has been occurred to the tissue or the heart muscle. And when we call it as a pathological Q waves means, yes, it is surely suggestive of infarction. And you see this. So this is the first upward deflection is the P wave. And the next deflection is supposed to be the inverted one, which is nothing but the Q wave. But here you can see how deep it is. Okay, when you know it is deep, yes, that is indicative or suggesting that, yes, the infarction is quite severe. Again, you have different types of myocardial infarction. All this you'll be learning as you go by, but just for information sake, you just have to know for now the non-STEMI and the STEMI. So non-STEMI again stands for non-ST segment elevation, and again elevation, and the other one is ST segment elevation. So here, and if you look at the ECG here, the red line that you see is nothing but your isoelectric line or the baseline of the ECG. So you will see the P wave is there. You have the slight Q wave, yes, up to the R wave, and as it comes down, then immediately below the red line is the wave is actually getting onto the ventricular repolarization, that is a T wave. That means what? There is a depression there. So that is means nothing but, yes, there is a non-segment, non-ST segment, ST segment myocardial infarction. And again, yes, there is the tissue has been damaged. The myocardial it has been projected to some kind of a damage, and it has to be taken care of. And also this also indicative of which portion of the heart is being damaged and how severe the condition is. Whereas in the ST segment elevation means, yes, it is a quite serious type of heart attack. So depression is considered as not that severe, but yes, it has to be treated. Attention has to be paid. It has to be rectified as early as possible. But when you see an ECG like this, that is above the isoelectric line and the wave, how high it is. So that is nothing but elevation. Okay. So here you definitely see the P wave, you see the tiny Q wave, yes, or till that it's okay. But when you see the R wave and then you see that it is not dipping down where it is supposed to, but there is an elevation, and then you see the T wave means, yes, it is a quite serious condition. It needs immediate management. So quickly the patient represents himself to the ED, and then once all the management or the immediate management is done in the emergency department, the patient has to be sent to the cath lab and the patient has to be managed effectively. Now, myocardial infarction, as I was just mentioning to you which portion of the heart is being affected. So what does that indicate? So when you know that there are ECG changes, because ECG also has, when I say 12 lead ECG, it's nothing but the 6 chest leads, the limb leads, and the AVR, AVL, AVF, lead 1, lead 2, lead 3. So V1 to V6, lead 1, lead 2, lead 3, AVR, AVL, AVF, all this together gives you the 12 lead ECG. Now, when you look at the ECG, and again, don't stress about this because all this will come only out of experience. So once you start working, once you start dealing with cardiac patients, once you start reading ECGs, only then this will come into play. But at least for now, you need to know just the basics, and just for information's sake, you can tell, or you need to know that the myocardial infarctions can be classified as anterior myocardial infarction, lateral myocardial infarction, septal myocardial infarction, inferior wall myocardial infarction, right ventricular myocardial infarction, and posterior myocardial infarction. So what is this actually indicating? When I say anterior, means the front portion of the heart is being affected. So if you're very thorough about where the heart where the coronary arteries of the heart actually supply blood. So that is why I say your anatomy is important. So once you look at the coronary arteries, the LAD or the left anterior descending artery is supplying the front portion of the heart. So that is why we call it that is damaged. Yes, you will definitely see the high myocardial elevation, ST segment elevation, and when that occurs, you know that yes, this is a, and such changes you will notice in the ECG where it is in V1, V2, V3, and V4. Okay, so that indicates the anterior wall myocardial infarction. So if you start to notice any changes in the ECG such as elevation or depression, in lead 1, AVL, V5 and V6, then that indicates the circumflex artery is being affected. So circumflex actually supplies the lateral wall of the heart. And any changes in the V1 and V2 like elevation or depression is noticed, then you know that the septal wall of the heart is being affected. So again, that is nothing but the artery involved over there again is the left anterior descending artery, because that is a septum. If you notice changes in the ECG in lead 2, 3 and AVF, that indicates inferior wall. Means again the right coronary, means inside portion. So that means the right coronary artery is being affected. V4, V5 and V6, if it's being affected, that means it indicates that the marginal branch. That is one of the branches that is supplying the heart, that is from the right side. That is the right coronary artery's branch is being blocked, or it is not receiving adequate blood supply. So that means it is a right ventricular infarct. And when you look at the ECG, and if you see changes in the V7, V8 and V9, then what happens there? Then that is nothing but indicative of the posterior wall myocardial infarction. Now, what are the causes for this kind of condition? So, the etiology for this would be, as I mentioned again, atherosclerosis to begin with, nothing but plaque formation, fatty deposits. Again, that is why we say your cholesterol levels are very important and it has to be managed thoroughly. Hypotension, any kind of coronary artery, any kind of coronary disease, what is that? Any kind of hypertension conditions and comorbidities. Also, sometimes it can be due to non-atherosclerotic conditions as well. So that means it always does not have to be the presence of plaque and atherosclerosis and fatty deposits. Sometimes even without all this, also it can occur. And what is that? It is truly related to the heart condition. So how healthy the heart is. Maybe the heart vessels are not healthy. It is always going into spasm. And that is what we learned in the previous session, like the Prince metal angina, where there is coronary vasospasm. Okay. Also, sometimes maybe there are some issues with the walls. Maybe it is hypertrophied. There is aortic stenosis or regurgitation that is again related to the valves. Maybe there is a congenital defect, that is birth defect, or also maybe some kind of a rupture or break in the coronary arteries, or some kind of emboli, or some kind of thrombus formation, and also maybe due to some kind of conduction defects due to hypothyroidism. All this can also be contributing factors to this particular. Now, the risk factors to myocardial infarction are classified as non-modifiable and modifiable. So again, non-modifiable means something that you cannot change. It is with you. So that includes your age, gender, your genetic factors, and the race and your ethnicity. That is your background. And the modifiable includes your lifestyle habits, your diet, your in the comorbidities condition, like whether you're a hypertensive patient or you've got high levels of sugar. All this can be controlled, modified, and changed. Also, your body weight, obesity, your stress levels, your cholesterol levels, all this, even though it is present, yes, we can bring about some changes in them, and that is called as the modifiable risk factors. So, now, what is the pathophysiology and why does this condition occur, or rather, how does it occur, and why do we call it as myocardial infarction? So, just as I explained to you in the beginning, looking at the pictures there, at least you know the different levels. So, how does it begin with? Like, it begins off with ischemia, injury, and then it ends up in infarction. So, that is the same way you write it as. And for that, why would all this begin? Again, it's due to the etiological factors. So, once the etiological factors are very present, yes, the person is going to experience ischemia. Again, what happens there? Eventually, the heart is going to be in a lot of demand, and when that is occurring, the tissue is going to be slowly proceeding towards injury and nothing but slightly getting damaged. That means the blood supply or the oxygen supply to the heart muscle is reduced. Okay, and that is when he presents with a condition like angina, and especially when there is presence of thrombus formation again, and maybe the person can end up having severe chest pain, or also called as unstable angina. And eventually this goes on, and the heart muscle can be thoroughly damaged or necrosed. And that condition, when there is complete necrosis, and that means that portion of the heart muscle is thoroughly damaged, and that is the myocardial infarction. So this is a pathophysiology of the condition myocardial. Now, what are the common signs and symptoms that the patient will experience? Yes, for sure, chest pain, chest discomfort, dyspnea, fatigue, profuse sweating. He may also feel nauseous, vomiting, lightheadedness, and definitely the heart rate may be increased, like arrhythmias. He may not be able to sleep, he cannot be able to lie down, breathlessness, and there may be drop in the blood pressure. And also, it is noticed that some of the patients again will have excessive vomiting sensations as well. Now, with myocardial infarction, the exclusive features or the signs and symptoms will include pain. And as I told you, this pain can be a crushing pain in the chest. Okay, maybe very severe throbbing. It can proceed or radiate to the neck, to the jaw, to the shoulder, and also sometimes in the left arm. Okay. Again, it may last for a few minutes to few hours. Again, once he presents himself immediately to the hospital, yes, attention can be given, management can be started. Again, you start off with nitroglycerin, like the little tablet you put underneath your tongue, and that is going to take care of the condition. So, and this is not recommended individually. This only happens at the hospital, and it has to be taken under medical supervision, and it's only the doctors and the nursing staff there will be able to administer this medication. The pulse is rapid and weak, against severe sweating, difficulty in breathing, and also what is happening, the ventricle is not able to pump effectively, and that is why the person is going to end up in a cardiogenic shock. Means there is no absolute cardiac output. And obviously, with all the investigations that is being done, and you will do a thorough history collection, blood investigation, and with all this ECG reports as well, they would come to the conclusion that the person is having a. The complications associated with this particular condition will include stroke, decreased cardiac output, ending up in cardiogenic shock. Congestive heart failure means again the heart is failing to pump effectively. Cardiac tamponade is another condition, again, where there is filling up of fluid, and arrhythmias, and also pericarditis. So nothing but inflammation of the heart muscle. So these are all the common complications you will see in this particular. Now, how do we diagnose this condition? Yes, again, mostly the same set of guidelines to follow: a thorough history collection, physical examination, ECG, blood investigations, chest X-ray, and as I mentioned to you, blood investigation is very important. You will be looking out for the cardiac enzymes and cardiac proteins, which is very, very important. Okay, so these are all the major measures you would do. Medical management, as I mentioned again, present himself to the to the ED as early as possible. So immediately at the ED, yes, the pain is severe. Again, as I told you, nitroglycerin will be put into the tongue, and the blood pressure will be monitored. He has to be monitored. Watch for the blood pressure. Watch for the saturation, the pulse, and also morphine sulfate can be given, that is to take care of the pain and discomfort. Again, depending upon, as I told you, the ECG, looking at it, and maybe there is a thrombus formation, so you'll be the patient will be given anticoagulants to thin the blood. Anti-angina is nothing but to take care of the pain, and the next step would be to send the patient for diagnostic investigation. Nothing but you're trying to find out by doing a angiogram what is exactly going on with the heart arteries. And even if that is not possible, that is no intervention can be done in the cath lab. That is nothing but if no stent can be put in to rectify the particular problem, then the next step of management will be the surgical. Now, in short, for the medical management, you can follow this particular acronym for myocardial infarction. You can call it as infarctions. So this is actually a short form. So you can actually follow this, which is nothing but INFARCTIONS. So I stands for IV access. So actually, this is actually a guideline to the emergency department staffs or the team. So immediately you put an IV line, narcotics or analgesics to be administered to help the patient relieve pain. In case the patient rhythm changes, yes, defibrillation is a choice. Aspirin, again, in order to inhibit the platelet aggregation. Rest is very important. That means comfortable position, rest, and also checking on the blood pressure, and also administering any kind of ACE inhibitors. Thrombolytics in case of any kind of clots present. Beta blockers again to tackle high blood pressure, and oxygen, as well as I think in case of any kind of where there is more of cardiac demand. Okay, so that means we need to reduce the workload on the heart, and that is what you will be presenting, or you will be administering the patient with some kind of nitrates as well. So this is actually just an acronym, so that probably the guideline for nurses or the staffs to follow, so that you know that you do not miss out. And this is actually the protocol or the guideline to be followed when a person or a patient presents to you with a myocardial. Putting in an intra-aortic balloon pump. Okay, that is nothing but it's a device that actually supports the heart ventricles to contract effectively. So the balloon pump actually contributes to the pumping action of the heart. Percutaneous coronary intervention with angioplasty is what I showed you yesterday, how you put the balloon and with a stent in case the blockage is more than 60%. If it is less than that, medications will take care of it. And if there are more than 3 or 4 blockages, then the person will be ideal for going for a surgery, and that is nothing but the coronary artery bypass graft. And minimal invasive direct coronary artery bypass is also being done, because these days with advancements in technology, even the bypass graft surgeries are quite helpful. And also these days they are performing the robotic surgery as well. Now, the nursing management will include, first of all, to begin with, a nursing assessment, that is history collection, physical examination, monitoring the vital signs, very, very important, performing the 12-lead ECG, IV access, sending the blood for investigations, chest x-ray, monitoring the saturations, the respiration, the heart rate, the pulse, and also obtaining the results. Okay, that's very important, because once we obtain the blood investigations that are being sent, only then you'll be able to judge and come to a conclusion about the diagnosis, about the impact or the intensity of the the ischemia or the injury to the heart. The nursing management, again, the first thing the nurse would do is provide a comfortable position, and as I told you, just follow that acronym of infarction. Okay, so those are all the nursing duties what you would be doing while the person is in ED, and the whole idea or the aim is to get the person to the cath lab as early as possible. So it is nothing but the earlier you take you do the quick management of the ED, and you send the person to the cath lab, then from there the time is, because that is called as the golden hour. Okay, once a person presents himself to the emergency department, and until the time where the management has actually been provided, that if you are able to fix that in that golden hour, okay, and that is in initial couple of hours, yes, the person is safe. We have avoided the injury to the heart muscle. So that is very, very crucial. So that actually all depends upon the effectiveness of the staff that are working in the department. So the earlier the better. Try to get the person to the cath lab, and then the cath lab team is going to be taking care of it, and then the person appropriate treatment will be given. And once a person actually receives a particular treatment, he is then shifted to the CCU, which is coronary care unit, under observation, monitoring, and especially if the person is on any kind of balloon pump, aortic, that is support devices. Okay, so that also has to be watched and monitored very closely, and just making sure everything goes well. Monitoring the vitals, again, very important. Also, maintaining the cardiac output is also very important. Fluids, also when you're the person may also be on in some kind of inotropes. All this is to support the heart muscle and just to reduce the workload or overload of the heart. So once a person is there, and he kind of the parameters are all settled, and he's stabilizing, very important that again he has to be observed and watched. The ECG has to be performed, and it has to be read thoroughly. And if everything looks okay, there is no damage, again, then it's good. The person is slowly shifted back to the ward, and then his nutritional needs are taken care of. The person's and the family's emotional needs or support is being given by the staff. Provide adequate health education and counseling, very, very important, and mainly assure the person about how he's going to be resuming his activities, because that's going to be also the concern for the patients once they are heading towards the discharge. And how to prevent the complications is nothing but how you prevent the risk factors. So you avoid those risk factors, then your complications are also being prevented. And also you would be you'll be telling about the importance of taking the medications on time, and you will also be telling him about the importance of getting the follow-up appointments, or the follow-up appointments, very very important, because you do not have to, you should not miss out on them. So that's also important, and the nurse will be guiding the patient and the family on this. Now, what is the nursing diagnosis? Yes, you know that the main clinical signs and symptom is chest pain. So definitely acute pain is the first priority nursing diagnosis, followed by decreased cardiac output. Yes, that's going to be dyspnea, so impaired gas exchange. Imbalanced nutritional status, because as I told you, the person will not be in a position to eat because he's going to be feeling nauseous, sometimes even vomiting. Activity intolerance, because again, yes, he's not going to be doing a lot of work because the body is demanding more, and there is already imbalance in the myocardial oxygen supply and the needs, because the heart is in a lot of pain and a lot of demand. So yes, the activity intolerance is seen. Anxiety, very, very important. Again, risk to the ineffective tissue perfusion. Okay, again, is because of what? Because of the decreased cardiac output. So the risks are also there, and also the whole idea is to avoid the patient ending up in these complications. And last but not the least is deficient knowledge. So knowledge, you will be talking or you'll be educating the patient and the family on a whole lot of, and that includes like right from dietary modifications that you can do, how you can eat all the healthy fats, reducing your junk food intake, your fatty intake, trying to manage your cholesterol levels at home, trying to be physically active, eating good fiber, okay, diet, and also like omega-3, which is something but good fats, okay, like that's all the eating fresh fish, and consuming good food, and managing your cholesterol levels, your blood level, your blood sugar levels, your blood levels are also to be kept under control. So even your stress modification has to be done, your coping levels should be increased, also coming out of all your other habits, which is smoking, alcohol, and increasing physical activity and exercise. Make sure you go for a walk, and at least for minimum 30 minutes, and also try to avoid those unwanted or intolerable weather conditions. And the whole idea is to keep yourself relaxed, to keep yourself happy, healthy, and keep yourself physically active. Also, as I told you, most importantly, managing your comorbid conditions. Very important, because these are for patients who have already got the or already having the existing comorbidities like hypertension, high diabetes, and trying to control them, keep them in the levels under control, because we know how all this can actually trigger to such drastic conditions. So all this information and education to be given both to the patient and the family who's going to be looking after him. And also very important, stress on the importance of the follow-up appointments and meeting the doctor as when planned. With that, we come to the end of this topic. Thank you for your time.